about that with Nina on Thursday. So they chronically retain CO2 and they live with hypoxemic drives, okay? So where their blood gas, what's normal for them is not normal for the rest of the population. So we have to understand if we see a certain blood gas, it could be normal for them, and I'm going to show you what that normal is, all right? So over time, COPD patients, they retain CO2, so their pH is going to be on the acidotic side, okay? You see the normal ranges here? So they're going to be around, if they're normal, if they're not sick, they're just living their daily normal lives, this is where they live, okay? So this would be a baseline gas for a COPD patient that lives with chronic CO2 retention. So their pH is going to be on the acidotic side, 7.35 to 7.39. It usually never overcompensates. It usually stays on the acidotic side because they live with high CO2s. So they're going to stay on the acidotic side. Their CO2s usually range around 50 to 60, okay, is their normal baseline CO2, okay? But they can go higher, even for their normal. That's not set in stone, they could go higher. They live with hypoxemic values for their oxygen. So their O2 could be 55 to 60 to 65, okay? All right, sometimes we would call COPD patients that have O2s in the 50s and CO2s in the 60s, we could call them 50-50 clubs or 60-60 clubs, because our O2 and CO2s fall in that range. So they live in the hypoxemic value here. And then their base excess. How do we fix if the patient has an acute respiratory acidosis, how does the body compensate for an acute respiratory acidosis? Huh? What are the kidneys going to do?
More alcohol.
They're going to hold on to bicarb, creating more of an alkalotic for the bicarb, right? So over time, these patients, they have lung disease, right? So they're not able to ventilate as well as normal people. So over time, they start retaining that carbon dioxide, okay? And by retaining the carbon dioxide, after even days, the kidneys, so it takes about 72 hours for kidneys to kick in, the kidneys start to retain bicarbonate, okay? Elevate the bicarbonate level, trying to compensate for that high acid. It elevates the bicarbonate level so that pH is normal, but it's normal on the acidotic side. Does that make sense? Okay. So let's look at a normal blood gas for a CO2 retainer. So not all COPD patients are chronic CO2 retainers. Just remember that. Is that clear? Clinically, they're not all retainers. But for test purposes, board purposes, anytime you see a patient that says COPD, assume that they are a retainer for testing purposes. Is that clear? Okay. So this would be an example of a baseline blood gas for a CO2 retainer. We have 737, okay, that's on the acidotic side, but it's still normal. The CO2 is 58, okay? So as long as that pH is normal, that's what we're looking at. That CO2 could be 70. As long as that pH says between 735 and 739, then you know that person's being compensated. And that's a baseline blood gas for them. Does that make sense? So we're always looking at that pH. If it's between 735 and 739, that gas is normal for that patient, all right? PaO2, well, we know they live on a hypoxemic drive, all right? So their O2s run low. So if we were to put their PaO2 up high, what would happen to their drive to breathe?
Increase.
It would suppress their drive to breathe, okay? It would suppress suppress their drive to breathe. So COPD patients stay with low oxygen levels, okay? We give them too much oxygen, it suppresses their drive to breathe, all right? Bicarbonate. So we said the kidneys are gonna hold on to bicarb, right? So you see you have a high bicarb level. The base excess is very high, okay? That's to compensate for that respiratory acidosis. So, the interpretation for a normal baseline, write this down. Interpretation for a normal baseline patient who is a CO2 retainer is a fully compensated chronic, the interpretation is here, fully compensated chronic respiratory acidosis with mild hypoxemia. Or whatever the oxygen is. I mean, well, that's normal, mild hypoxemia usually. If it's below 60, then it would be mild or moderate. We call this chronic because these patients have lived with this for a while, okay? So it's a chronic acidosis, but it's been compensated by the kidneys, and the patient lives this way. This is their normal baseline blood gas, all right? So if you saw a blood gas like this, and you were asked to intervene, it could tell you, do you want to give them oxygen? Because the PO2 is 60, right? Do you want to give them oxygen? Do you want to ventilate them because their pH, their CO2 is 58, okay? Or do you want to stay, do you want to do nothing, okay? The answer is do not intervene. That is the perfect blood gas for a COPD patient that's a CO2 retainer, okay? The O2, 55 to 65 is their range, okay? The CO2 high, I can't tell you exactly what it is, but it's high. pH, 735 to 739. If it's in that range, that is their baseline. There's no need, there's no reason to treat. Okay? So on quizzes, you're going to have to interpret these blood gases for COPD patients. And we're going to practice this in the lab workbooks today. All right? Okay, so this is a normal blood gas for a chronic CO2 retainer. Okay, so here, severe COPD unstable. So here we have, let's see, patient has become more hypoxemic than his body's used to. So look what happens. His O2 was 55, right? Now we're at 48. So is that hypoxemic for this patient? Yes, below 55 is hypoxemic for this patient, correct? So, what does the patient do if it's lower than their baseline? What does the body do to compensate for hypoxemia? What does the body do, Jovi? They start to pick up breathing, right? There's J receptors in there, and if they see low O2s, lower than their norm, tells the brain to start breathing faster so that they bring in more oxygen to the blood. Okay? So they start breathing faster, and they create a respiratory alkalosis. Now, 745 is normal for a non-COPD patient, right? But it's not normal for a COPD patient. All right? So look here. So we have, what was our pH? It was 739, the last pH?
737.
737? Okay. So 737, our CO2 was 55?
Yeah.
Okay, now it's 48. Why is it 48, 745? Why has the CO2 come down from 55 to 48?
Because he's breathing in more oxygen and his CO2 is leaving his body.
Because, say that again, Henry?
Because he's breathing in more oxygen and his CO2 is leaving his body.
Right, because he has the need to bring in more oxygen, to raise his oxygen level. So he's breathing faster, blowing off his CO2 from his normal baseline from
Yeah.
55 to 48, okay? And that's causing his pH to become more alkalitic. Make sense? So, how would you treat this patient? First, let's do the interpretation of this, and then we'll talk about how we treat. Okay, so it says here at first glance, we might call this a fully compensated metabolic alkalosis, but that's not how we interpret this blood gas. Okay, we know that this is a physiological response to hypoxemia, because he's trying to breathe to get in more oxygen to his body. So let's see what we call this. We're not interpreting it yet. Okay, here's the interpretation, and we'll go back. So, when the patient is hyperventilating from their normal baseline, all right, he's raised his pH, he's lowered his CO2, that's an acute issue. Chronic means he's had it for a very long time. Okay, so the first blood gas we said, what did we call the first blood gas? So, the first one we said fully compensated chronic, we use that word chronic respiratory acidosis. It's very appropriate for a normal blood gas. Now the patient's having a new onset of something. Maybe they have an infection in their lungs. Maybe they have pneumonia. And their oxygen is dropping, so they're becoming hypoxemic, causing them to breathe faster. All right, make sense? When they breathe faster, because this is a new problem, we call this an acute. All right, it's a new problem. So we say that 745 is not normal for this patient, and he's hyperventilating because he's hypoxemic from his normal O2 level. So we're going to call this an acute respiratory alkalosis, okay? Because that's a respiratory alkalosis for this patient. Make sense? So it's an acute respiratory alkalosis, and it's superimposed, meaning it's on top of a chronic condition that he lives with. Superimposed on a chronic respiratory acidosis with moderate hypoxemia. So take that in for a second.
What do you say superposed?
Well, there's an underlying chronic problem with this patient. He retains bicarbonate, right?
Yeah.
For a chronic CO2 retention. Okay? So we know underlying there's a chronic problem. This patient is a CO2 retainer. All right? That's the chronic respiratory acidosis we're looking at. But on top of that, now he's hypoxemic, so he's creating a respiratory alkalosis from his baseline. Does that make sense? Henry? Remember his CO2 was 55, his normal?
Yeah.
But he's breathing so fast, he's blowing off his CO2 to be 48.
Mm-hmm.
And that's causing his pH to go from 737 to 745.
Mm-hmm.
So that's a respiratory alkalosis for him. That's different than his norm, right?
Yeah.
So he's blowing off his CO2. His normal CO2 is 55. How do I know that? Because he had a normal pH with that 55. So that's where he lives. He lives with a CO2 of 55. Does that make sense to you, Henry? Okay, so this is how you would interpret this blood gas. And we're going to be doing that in your lab workbook today. So we know there's an underlying chronic condition. This patient's a CO2 retainer. But all of a sudden, he developed an infection. Maybe he got pneumonia. And now he's sick, and now his oxygen level is dropping because of it, and his body is breathing faster. So he's blowing off his CO2. So we have a new onset problem, which we call an acute. That's new because he's sick. With a chronic, superimposed on a chronic, he has a chronic condition where he lives. Are we good with that?
Yeah.
told you, I know his CO2 was normal at 55, that's where he lives, because he had a normal pH, right? But there's a even more scientific way to determine what that person's CO2 should be. Where do they really live at? Well, I'm going to show it to you. You guys kind of already went over this with Nina. Okay, so when we look at, do you remember using 0.6?
No,
Right?
they don't know that, Joni. They
Oh, I
only
thought you
know,
said
they
you
only
never-
know the Henderson-Hasselbalch equation is the ratio between, pH is calculated by the ratio between,
Your
by base and acid.
base and acid. So using the Henderson-Hasselbalch equation, that equation is looking at base and acid, and the difference between the two is where you get this 0.6. Okay, so it says here, normal bicarb is 24, divided by the normal CO2, which is 40, from the Henderson-Hasselbalch equation, and your answer is 0.6. Okay, that's where we get that number. So it says, if we take this patient's bicarb and divide it by the factor of 0.6, we can see what the patient's baseline CO2 should be. Okay, so I told you I know that it was normal, because pH was normal. But now, if I see a patient's CO2, I want to say, hey, is that really their normal? Okay, like if that's not a normal pH, I can find out what the normal is by, okay, so you take the bicarbonate of your patient's blood gas and divide it by 0.6. Okay, so for this patient here, we took 35.1, that was the bicarb, divided it by 0.6, and this is the answer. So for this patient, his normal PaCO2 is going to be 58.5. So we'll look at a couple others. I'll give you an example of one, let's see. Okay, so I want you to do this one. I want you to tell me, with this blood gas right here, what is this patient's normal CO2? How do we do it? We just did it, I just want you to practice.
35.1
divided by
48.
0.6.
0.6,
Okay, and what's your answer? This is what you're going to be doing anytime you have a patient that is a CO2 retainer, to find out their normal PCO2. 58.5, that's your answer, okay? So in any blood gas, that's what you're going to do to find out the patient's normal CO2, okay? So you've got this interpretation, acute respiratory alkalosis, because that's the acute problem with this blood gas, superimposed on a chronic respiratory acidosis, because that's the patient's normal status, that's where they live. Does that make sense? Yes, Henry?
Yeah.
Okay. All right. So you didn't do the last one, which is acute respiratory acidosis? You just did acute respiratory alkalosis?
No, there's no acute respiratory acidosis in there. Let me see. The first one?
That's normal.
Okay, let me see. Oh, I thought I did.
Yeah, I'll just
I
add
mean,
it.
the major
but
problem
I'm gonna add
is
it.
this.
Yeah.
The big problem is this, Joni, the alkalosis. So if
there's
you see,
another interpretation.
so if you see any blood gas in your workbooks, if you see any patient scenario in your workbooks or in your quizzes or exams that says you are taking care of a COPD patient, assume that they are a severe COPD patient and you should have blood gases. His normal blood gas should be on the acidotic side of normal for the pH a CO2, it's not CO2 driven, but they run higher CO2s, but they normalize their pH, okay? So as soon as you see that, looking at a blood gas and calling it a metabolic alkalosis is gonna be wrong. So assume all those people are retainers, and take the bicarbonate you're given and divide it by 0.6 to see where that patient should normally live. And if it's lower than that, look at your oxygenation and say, is he hypoxemic? Because then he's gonna get tachypnic, okay? If it's much higher than that, he has an acute respiratory acidosis on top of a chronic. So what you're doing is recognizing the fact that this guy normally has, these patients normally have chronic respiratory acidosis, which is compensated for. It's when they're having problems that people don't recognize it. And if they're more hypoxemic than normal, they're gonna start breathing fast and they'll bring down their normal CO2, their normal, lower. And they'll push their pH to the alkalotic side. So whenever you see COPD patient, think to yourself, if those gases are not running like they should be, take his bicarb, divide it by 0.6, and that will tell you where he normally lives. And then look and see, why isn't he like that? If it's lower than that, maybe he's hypoxemic. If it's much higher than that, he's having trouble breathing, or his PO2 has gotten too high and it's knocked out his drive. Does that make sense? Okay, so whenever you see COPD patient, on any other patient where we're not talking about COPD, all bets are off the table. Then you analyze it the way you normally would, okay?
So guys, I want you to write down these 3 blood gases. There's 3 scenarios.
Can you turn on the light?
You want the light on?
Yeah.
Is that better?
Yeah.
There's not a black marker up there, huh?
There's not a black marker now. I need to get one. And you see the red's easier than the green at least.
Yeah, because I thought I grabbed the black. I don't have one down there.
This is blue, are we used, I wonder if these are dry erasers. Oh,
Yes,
they
they are dry erasers.
are.
And somebody took it, because I had brought up all.
Okay. Okay, so this is the COPD patient, and the scenario will be, a COPD patient came into the ED. You do a blood gas. This is your blood gas, how do you treat them? Okay? So, interpret the first blood gas for me. What are we gonna call this? What do we say?
Fully compensated. Fully compensated.
So this one here is a fully compensated. It's good to have all 3 next to each other so you can see the difference. Fully compensated. Go ahead. Chronic. Respiratory acidosis. And everybody knows this little C is with what? So you always still do the oxygen exactly as you were taught, okay? With mild hypoxemia, okay? With mild hypoxemia. Okay? All right, that's your first
What is C
interpretation.
again?
Pardon me?
What is C again?
This is with.
Wait, okay.
C with the line on top is with.
Okay.
P with the line on top is after. S with the line on top is without. That's medical terminology. Okay, if you see this blood gas and it asks, do you want to give oxygen? Because oh my goodness, your O2 is 60. Do you want to give 2-liter nasal cannula? Do you want to give a non-rebreather? Or do you not want to treat this patient? It'll give you options, right? What is your answer? Do not treat. Your patient is in their normal status. This is where they live at home. They don't use oxygen at home, maybe. maybe not, but this is their normal baseline, okay? And you can put above it normal baseline. Baseline. Okay, now, here's your second blood gas that we just discussed, okay? Tell me about this in blood gas. Can you tell me what's happening? Show me what's happening with this blood gas. So it dropped. So this patient is hypoxemic, right? So he's hypoxemic from his normal level. And because he's hypoxemic, what is he doing?
Really fast.
He's hyperventilating from his normal base, right? His CO2, he's blowing off more CO2. You know what? I did that wrong, guys. Change that. That is not correct. It should be, yeah, no, that's right. That is right. 47. So he is blowing off his CO2 from his norm, which was 55. That's correct. Okay? Okay. So, what's the interpretation of this blood gas? Okay, so it's an acute. What is it?
Respiratory alkalosis.
Uh-huh.
Superimposed with chronic respiratory acidosis with moderate hypoxemia.
Superimposed.
With respiratory.
Say that again.
chronic-
Superimposed with.
Chronic respiratory acidosis.
Chronic respiratory acidosis. With what kind of oxygen?
Moderate hypoxemia.
With moderate hypoxemia. So we know this patient has an underlying condition. He lives with a chronic respiratory acidosis, okay? But right now, he's hyperventilating from his normal baseline. Does everyone make sense with that? Tatea? This is not his normal. He has a lower CO2, a lower O2, his CO2 is lower, and his pH is above 739.
That's what you call acute
That's why
respiratory.
we're saying acute.
Yeah, acute respiratory alkalosis, right?
Yes.
And
Yes.
and the next interpretation is the superimpose with the chronic respiratory acidosis is where you get from. It's get from the
Because he has a high bicarb,
high bicarb
and his base excess is high.
Okay.
So he's living with high values there.
Okay.
Okay, and in the scenario, it's going to tell you COPD. If you see COPD and you have a high bicarb in it, then you're going to assume that they're a CO2 retainer. Okay? Now we have one more scenario. Okay? So this patient came in, he had pneumonia, all right? His oxygen was low, so he was hypoxemic. So his body said, his brain said, you need to breathe faster. So now he's hyperventilating, blowing off that CO2, okay? So he's been doing that for 10 hours now. And now he's getting tired. COPD patients have very little reserve. So he's getting tired, his muscles are tiring out. So now he's not able to blow off the CO2 anymore, okay, because of his hypoxemia. So we can use the same O2. Let's use the same O2. So what's happening here? So he goes from here, this blood gas, to this blood gas. What's happening here? What's the acute problem here?
CO2 is high.
It's higher than his normal, right?
Yeah.
He was hyperventilating to try to bring in more oxygen to his body, but now he's tiring. So he's starting to retain CO2. And what's happening to the pH?
It's lower.
It's lower. What's his normal pH? 735 to 739.
Yeah.
It's below his normal. So is this an acute problem? Yes. So we're going to say this is an acute respiratory. So here we said an acute respiratory alkalosis. What are we going to call this one?
Acidosis?
Acute respiratory acidosis. Tell me what to write next.
So did you say superimposed?
Huh? Yep. Superimposed. Superimposed. And we can really say on a. Keep telling me, what do I write? Chronic respiratory acidosis with moderate
Hypoxemia.
hypoxemia. So
Can you-
isn't that interesting that we have an acute respiratory acidosis on top of his chronic problem? Okay, so he's retaining more CO2 than he normally lives at because he's tiring out. He's going into respiratory failure. He's heading in that direction. He's tiring out, okay? So so if you were to pick, we would have to ventilate this patient because the ventilation is being compromised. So we might have to put this patient on what device if he's having an acute respiratory acidosis? Nope, so it's gonna help with the CO2. We're gonna assist with his ventilation. What device did you just learn about that assists with ventilation? Helps to blow off the CO2. BiPAP. So this guy needs BiPAP. Okay? This one, if he wasn't responding to oxygen, then this one, he doesn't have a respiratory issue. He has an oxygenation issue. So if we increased our oxygen, what device could you put this one on?
CCAP.
CPAP fixes oxygen problems, and BiPAP fixes ventilation problems. It fixes oxygen and ventilation problems. Make sense?
We're ready.
This kind of breaks it down for you in 3 sections. Okay? All right. You're gonna drink. Okay, so guys, you should probably put your gowns on and your face shield. Unless you want to just wear your glasses. You can wear your glasses if you want, or a face shield.
What do those guys, what do you guys have? Did you hand out that?
I did.
Hold on.
I did hand it, I think you did. They're over here.
Okay.
I put them over here.
Yeah, I got it. I just need. I got it here, that file. And one of you guys, we're gonna divide into, 2 groups of 3, and we're gonna be over here. One of you in your group, bring over your cell phone for a stopwatch.
Hey, I didn't show you guys that other Maybe at the end of class, if we have time, I'll show it to you. The PowerPoint that I reposted, please look at it, okay? On CPAP. All right, let me grab my PowerPoint.
And grab a clipboard from underneath there, guys.
See, we're not gonna do the right, we're just gonna measure here.
Thank you.
Where the arrow, set up the arrow for compliance. Where's the color? Right arrow is reset on the same level as the compliance. Okay, so, we're gonna work through this together. So, we're gonna be in front of this machine and looking at, here, I have to turn this around, because the manometer on that one doesn't work. So they have to use this.
Oh, okay.
Okay, okay. And then 3 people are gonna be standing here with me. So, grab 3 chairs, bring
You
them over
describe 3
here,
chairs, you 3
and
just
flip
sit
one,
right there.
and then 3 over here. Okay. Alright, there you go. Okay, so from this point on, guys, did I tell you guys, these are called lung simulators, okay? And you can adjust airway resistance by putting on different adapters to simulate. You can put on airway resistors to simulate increased airway resistance, okay? We can
You got
also
it, 50.
change, you got one.
Yeah, I smashed it.
Yes, I'm gonna have to change them to 5s in a second. That's for the resistance one. And you can adjust a patient's lung compliance.
Pretty cool.
So, the first thing we're gonna be doing, when you look at these labs,
I can
okay?
get a lab manual or the glucose
Do
manual?
you have the lab manual?
Oh, see, he wasn't in the room.
Okay,
So, IPPB, there you go, Nina.
okay. So look at page 2. Don't pay attention to page 1, okay, because we're running that differently. So today we're gonna be looking at IPPB to get the concepts. Did you see the other Draeger that was plugged in over there? There were 2 Draegers plugged in next to each other? Don't tell me somebody took the Draeger. That's your VN500 that was supposed to charge, oh, no, I'm sorry, that was supposed to charge for 48 hours. It was the 2 servos that were over there, so for
Yeah, the
48
2
hours.
servers are right there.
Yeah, that's fine. So for 48, that can be unplugged now, but he said leave it plugged in for 48 hours for the battery charge.
And then we can leave them unplugged.
He didn't say anything.
Yeah, where that guy said we had to keep those. plugged
Okay,
in.
okay. All right, so the first page, what's our activity? What are we doing? It's right on the top in big block letters, which most people don't read. Yes, so based on yesterday, so we're looking at, we're gonna prove that what happens, what is the pressure dial in charge of with IPPB? If you increase the pressure or decrease the pressure, what's that going to affect?
The volume?
The volume.
Good.
If you increase the pressure, you'll increase the volume. If you decrease the pressure, you decrease the volume. That is because what ends inspiration in IPPB? Of the factors of flow, volume, pressure, or time, what cycles inspiration in IPPB? Pressure. So if you increase the pressure, it's gonna cycle later, putting more, and you're gonna put more volume into the patient, because as soon as you turn on the IPPB machine, feel it.
positive pressure?
So, as soon as I turn it on,
Breathing that in, you're pushing it
there's we're gonna be starting on a 5. Here's a 5.
Here's your 15.
50 and what's the other 5?
So we're gonna be doing normal compliance.
Yeah. So, as soon as I turn the machine on, what's happening to the patient's lungs? What's happening?
Inflated.
It's deflating, inflating, and then deflating. Where's the cycle? If you're looking at the front of this, where's the cycle? Pressure manometer.
Someone tell me the
You
pressure,
guys
'cause I
obviously can't see it. You gotta
I
get
can't
up and
see it.
move over here and look. Where is it cycling?
Pause.
You gotta get head on.
See, my manometer here doesn't work.
What do you guess it, no, it doesn't. That's why I have that yeah, circle over there with you. Yeah,
Looks like it's going to 10.
it is, it should be, because I said it already.
You guys see this one over here? Going 10, okay?
10, right? Okay,
This
now,
manometer's not working.
10 centimeters of water pressure. You come over here, because this is what you're gonna be doing for this lab.
Hey,
Okay,
can
you
we
guys
just
are
tell them
gonna,
the difference between manometer and cuff later, just so everybody understands that?
manometer measures pressure on these machines.
On a machine.
Okay? The cufflator measures pressure for the ET tube cuff pressure, okay? All right, it's always measured in centimeters of water pressure. All right, to read the volume that is going in, you're gonna have to come around me. To read the volume that's going in, I look at where my compliance is set. Everybody with me? And it's set at 0.05 liters per centimeter of water pressure. In other words, I can put in 50 milliliters of volume for every centimeter of pressure that I'm generating. So, if that is the case, how much tidal volume should I be delivering to this patient? The lung compliance is 50 milliliters per centimeter of pressure. I am cycling at 10 centimeters of pressure. That's how you understand compliance.
Right. You have to do math.
Compliance means the lungs can expand for every centimeter of pressure that I apply to that patient's lungs. I can put in 50 milliliters of gas. Instead of 1 centimeter of pressure, I'm applying 10 centimeters of pressure. How much tidal volume can I get into the patient? 500
Good.
milliliters. For every centimeter, I can put in 50 milliliters. For 2 centimeters, I can put in 100. 3 centimeters, I can put in 150. 50 times 3. I am exposing this patient to 10 centimeters of pressure. So for his compliance of 50 milliliters per centimeter of pressure, 50 times 10 is a tidal volume of 500. If his compliance was 20 mils per centimeter of water pressure and I applied the same pressure, how much volume could I get in? 20 milliliters per centimeter of pressure. Is that a decrease or an increase in
What'd you say, Jen?
compliance? No, she asked me the compliance. So if I'm putting in, if the compliance changes to 20 mils per centimeter of water pressure, you know what, we need calculators, Joan. You want to grab it from your own?
Yeah, I can
Would
get
you
it.
mind? Okay, so now, if the compliance is now 20 mils per centimeter of water pressure instead of 50 mils per centimeter of water pressure, is that an increase or decrease in compliance? It's a decrease in compliance. If the pressure remains the same, 10 centimeters of pressure, is the volume going in going to change?
Yes.
Absolutely. Good. So if I'm now still using 10 centimeters of water pressure to ventilate, what's my tidal volume going to be now if the compliance is now 20 milliliters?
200.
200, right?
Yeah.
Good. So When compliance decreases, what happens to tidal volume with IPPB? It will decrease. If you have a compliance of 50 mils per centimeter of water pressure and I'm using 10 centimeters, if you guys are too hot with your visors, you can take them off. It's up to you. And you have your N95s on, so it's totally up to you, okay? So, now, because I don't want anybody passing out. Okay, so if you had a compliance of 50 mils per centimeter of water pressure and you were using 10 centimeters of water pressure to ventilate, the tidal volume would be 500. If the patient's lung compliance changes because he develops a huge amount of atelectasis, and all of a sudden, his compliance dropped to 20 mils per centimeter of pressure, ventilating at the same 10 would now give you a tidal volume of 200. Does that make sense? Okay, if the airway resistance goes up, okay, the mouth pressure and alveolar pressure is going to equalize sooner. What's going to happen to the tidal volume that is delivered? It will decrease, okay? What we're gonna do is prove all of these things today, okay? That's what we're doing. Right now, the first thing we're gonna do is, you got it. Okay, thanks, John. What's our exercise with the first thing? Does it look like we're going to do? We're going to compare something, and you're gonna put it in the boxes. Right here. Right here, look, everybody look up. What are we gonna compare?
Tidal volume and trigger?
Not tidal volume, look at right here. I want you to look at right here. Pressure and time. So, we're going to be turning the pressure from 10, and we're gonna record the tidal volume and the inspiratory time. We're gonna leave the flow rate the same. Flow rate is responsible for I time, along with pressure. We're gonna leave the flow rate the same for both. We're going to increase the pressure from 10 up to 20. You're gonna record the inspiratory time, hence we need a stopwatch, okay? Both machines will slightly differ on inspiratory time, okay? And we're gonna record the volume. So everybody knows where to look for the volume. If you're set on a compliance here, this compliance on the side is always in liters per centimeter of water pressure. So move the decimal over three to the right, and that's 50 milliliters per centimeter of pressure. Everybody see that? Do you see that? So when I ask you guys to record the volume, when you're set at 50, this arrow up here has to be set at 50. When the lung inflates, every single one of these lines is 100 milliliters. So when we get up to this line, that's 500 milliliters. Up to this line, it's 1,000 milliliters. So we need to eyeball both this and the stopwatch for time. Sometimes it's hard, so we may have to run it twice. When I said yesterday that these numbers here are only reference points, here's an example as to why. I just marked them for what would be approximately 10 or 15. Okay, but if you lift this up,
And this one here, you didn't turn this
this
on?
is the reference point for 15. Okay, and 15 is actually down here. Okay, so that's why you always look at the manometer, which is busted on that machine. That's why we have this.
Did you do anything with the flow here?
Yes, I did.
So it's just broken.
The flow, it does not work. And the
Okay.
flow is only reference points, okay? So we have 35, 30,
Just take the words.
and 20, okay? So we're gonna be looking at different flow rates. So, with the first exercise, you guys already told me, based on what you learned yesterday, if you increase pressure, what happens to tidal volume? Goes up. If you increase pressure, what happens to the TI? The inspiratory time is TI. If you increase pressure, what happens to TI? Huh? If you increase pressure, is it gonna take longer to get to that set pressure?
No, not faster.
The only thing that would make it go faster, Taya, is if I change the flow rate.
Flow rate.
The flow rate is constant. In the example here, we're keeping the same flow rate. If I increase the pressure and I wanted it to go in for the same amount of time as the first breath, what would I have to do?
Say it again.
If I increase the pressure So now it's taking a longer time, okay? Pressure is like the distance you have to drive. If I tell, so you'll be able to get this, if I tell you, you have to drive to Upper Marlboro, and you're going 50 miles an hour. And now if I tell you, you have to drive to St. Mary's County in the same amount of time, what are you gonna do? Increase the gas flow,
Speed.
increase the speed. You have to think of mechanical ventilation whenever we talk about a car, okay? Flow rate is the gas pedal. The end point, or the pressure, is going to be where you have to go. How long it takes you to get there is the TI. That's the flow rate. Got it? Okay. Okay, so, we're not changing the flow rate. But if we wanted to take the same amount of time to get more pressure in, what would we do?
Increase the pressure.
Increase the what?
Pressure.
No.
It's just the
If
flow.
we increase the pressure and we wanna take the same amount of time, no longer, than we did in the first example, how could you fix that?
Increase the flow.
Increase the
Increase the
flow
flow.
rate. Good. Now, we're not gonna do that. Flow rate's gonna be standard right now, so we should be having our flow rate at, 30 liters a minute.
Okay, so you want me to go back to 30?
Yeah. Okay.
Okay, so
Now,
30.
Joni's gonna be working that machine, okay? So just give him a test run and show him how the manometer
Yeah,
pops off at
just they're
10,
gonna show
and
me.
you guys watch here, the manometer will pop off at 10. Okay?
So you can push in this little toggle.
That's your
here.
sensitivity.
Yeah, that's your.
Oh, Joni, you know what? Dial that sensitivity.
Why don't you show them the different things
Yeah.
before we start on the
Yeah,
IPPB?
Of course, I'm not gonna be able to get this to cycle.
Now, hospitals don't have these anymore. These are so antiquated. These were the first ventilators, besides negative pressure ventilators. They used these to ventilate patients coming in that were not breathing. So they are the very first ventilators. Bird Mark
See this?
7.
It's cycling by itself. I'm not doing anything. It's just cycling by itself. How is it doing that? Okay, inside of these things, there's a big magnet and a steel plate, all right? The closer you bring the magnet to the plate, all right, the harder it is to trigger, all right, because you're trying to pull it away from it. All right, so I have to adjust, so if a patient was doing this, making no effort to breathe and had it in their mouth, what's going to happen? It just would trigger. So what's gonna happen to their CO2 in their head? It's gonna go down, and it's gonna, and the blood vessels are gonna vasoconstrict in the head, so then they're gonna start feeling dizzy. And here's a scenario you could get. You're doing IPPB, patient is 60 kilograms, you're delivering a tidal volume of 700, patient is complaining of dizziness, and what are you gonna tell them to do? You're gonna tell them to slow down their breathing. If I tell you the patient is 60 kilograms and the return volume is 1 liter and they're they're complaining of dizziness, what are you gonna do? 60 kilograms, return volume is 1,000, okay? And the patient is complaining of the same symptoms. Do you tell them to slow their breathing down?
Yeah.
No, because in this case, what's the volume you're supposed to deliver to a patient? It's supposed to be between 10 and 15 mils per kilo. 15 times 60 is 900. So if that patient's tidal volume is 1,000, you're doing the hyperventilation for them. However, if you're within the volume you should be and they're complaining of that, look for somewhere in the scenario that says that they're breathing rapidly. Tell them to slow down their breathing. The fix is dependent on the scenario. Okay? Okay, all right, so let's go ahead and move through this. So we have a pressure of 10. So these are reference numbers here, so I just need to get this to stop auto-cycling. Is that yours that's doing it or mine?
No, it's not mine.
Okay.
Mine is.
So I just
I
brought
have to
the
keep
magnet
mine.
much closer to the
Do it.
plate in here, so it's harder for it to auto-cycle. Okay, look in here. The thing that looks like a crown
What
is
is
the
yours
magnet.
on? Mine's on 10.
No, it doesn't matter what it's on, as long as you can cycle the machine without that's too hard. So you have to push it in to cycle it. So make it
So do you guys
more
realize,
sensitive, Joni.
What is her set on, what number?
It doesn't matter, I don't have it on a number.
You don't have any numbers?
No, I'm telling you, it goes from
So
5
mine's
to
on
40.
Right, so 5 being more sensitive, okay, the higher number being less sensitive.
But look at your magnets.
No, that's why, but on right now, I just set it to 7. On 10, as a reference number, it wasn't triggering, auto triggering.
So
Okay?
put it
So I
all
just
the
set
way
it to
up, Joni, for them, and they can see how the magnet
I'm gonna
gets
put it all the
closer
way,
to the steel
very
plate.
sensitive.
Guys, are you working on that over there?
Come on over here.
So it's very sensitive, the magnet is far away from the plate.
Yeah, come on over here. So I have it at the most sensitive. See my black is all the way here? Very, very sensitive, right? Here's your magnet. Can you see the magnet in the plate?
Magnet is on the sensitivity side, the sensitivity side of the machine.
Okay, so you see that magnet there?
No, Joni,
Huh?
this side, the magnet is for the sensitivity.
It's
Okay.
hard to see anything because of
Okay,
this,
come over here. Come
because
over
I have
here.
this taped.
That's fine, come over here. Okay, there's magnets on both sides, one for pressure, one for sensitivity, okay? So, see how close the magnet is to the steel plate? See that?
Yeah,
Okay,
I can't even see
so
that.
it's not gonna auto trigger, okay? In fact, it's kinda hard for me to push it in, all right? If I bring the magnet all the way far away, it's very easy for the machine to just auto trigger.
Let me see yours. So you do have numbers. That's what I was
I
asking.
said I have numbers, but I'm not on any of the numbers, so I couldn't tell you what number I'm on. So right now, I'm at 5, and the magnet is very far away from the steel plate, so it's auto triggering. Okay, if I bring the magnet very close, okay, it's harder to trigger. Okay, because it's easier for the magnet, it's harder for the magnet, the plate to pull away from the magnet. Okay, so that's why these numbers don't mean anything. They're just reference numbers, that's it. Your sensitivity is not gonna be set between here and here. You've got the whole realm here. So what are you gonna look for to make sure the sensitivity is set correctly?
No pressure.
When the patient breathes, how far do you want this manometer to drop back?
-2.
1 to 2, and then you've got doesn't matter where this is, then you have the sensitivity set right. If this drops back to -1 or -2, then the breath starts, okay? Okay, so Joni will work that machine, and you're going to, who's got the stopwatch? Okay, and you guys got the stopwatch over there? Okay, so first you're setting it at 10, I think Joni has it set on 10 over there, you set
I
it?
do.
Okay, all right, so what you're gonna be
So
looking
pressure
for,
on this
one
side,
person is gonna
sensitivity on that
stand and
side.
read the volume, okay?
So they both have numbers.
Okay, all right, or two, and one, who's gonna do the stopwatch? As soon as you hear it turn on, you hit it and then stop it, okay? So, ready to
Pressure,
roll?
sensitivity, manometer, okay?
Okay, ready to
This is
go?
your air mix.
All right,
where it
1,
mixes air and oxygen.
2,
Okay?
3.
So, what's the first thing we're gonna do here? We're at 10 of pressure,
What was the volume?
we're there, and we're gonna
Which it
look
should
at
be,
exhale
that's it.
volume.
Okay,
and
so everybody
time.
write 500,
So as
and
soon
how
as it
long is
starts-
the TI?
We're gonna count in seconds how long it takes.
Come on.
Okay, so I'm gonna trigger this
3.85 seconds, so
device
write
here.
that down, 3.85 seconds. TI is, exhale volume
What
is
was my volume?
500 milliliters.
So you pay attention to the volume,
3.8,
wherever it
write the
ends,
hundredths,
you let us know what the
85
volume
seconds.
is.
That was your
And you're doing time.
TI.
Let's try it
Okay?
again.
Now, if I go to a pressure of 15,
What was that volume?
should I get more volume in? How much volume? At 50 mils per
500?
centimeter of water pressure.
500, look like 500 to me. Let's do it one more time.
You said 15?
We're set at 15, and the compliance is 50 mils per centimeter of
look like
water pressure.
500.
Right?
Good, so write down 500
Right? So how
For
much
exhale
tidal
tidal
volume
volume
can we
is
get at this
500.
time?
for 10 centimeters.
Water
Water pressure, 500 milliliters. Make sure you put that
Compliance is
milliliters.
50 mils per centimeter of water pressure.
And how long
I'm
did
now
that take?
increasing the pressure to 15. How much tidal volume do you
Okay,
think I
so
can get?
4 seconds was your time.
750, so you read and see if 750 is what you get, and when I'll say go, Sean, so that you know
Did you
when I'm
guys
gonna
get 4
press it.
seconds?
One, it's not gonna be exact same, because we can't titrate the flow, 3.85. And you guys have to write the hundredths down, because sometimes they're super close, okay?
All right,
Okay,
so
ready to
now,
roll?
we're gonna go to 20 centimeters
Ready,
of pressure.
set,
Pressure's
go.
on this side, sensitivity's on that side. So now let's take this to 20. Okay. All right, you guys ready? Now you're gonna watch the volume and watch the time.
hello?
Can we do it again?
Yes, we can. So, ready, set, go.
What was it, Lorna? Try it again. Ready?
About 650.
650? It could be off a little bit. Was it popping off at 15 here?
It was like 1.2, didn't it? That's what I think. So 1.2 liters.
Something's wrong. They're
Yeah, my
not popping
pressure's
off at
way
15.
too high.
It should, then they need to watch the manometer, because you should be getting an entitled volume of 750, right? Did you guys calculate that beforehand? If you
Yeah,
increase the
look.
pressure to 15?
See what our pressure is for 20. So we need to adjust this to match this.
10, 11.
That was 20, right?
Right here,
Did it
15.
say 20?
Oh,
So
okay.
calculate, what did you say? How much
Okay, so
volume
that's
should you
15.
get in when you have a compliance of
750.
50 milliliters per centimeter blood pressure? So it would be 50 times 20. What is that? 1,000.
About 700,
So you
it's
should get at
close.
least 1,000.
Here's what I want you to do.
Right? That's
Write
what we should put in.
750. Because
But
it's
here,
give or take,
let's look
okay,
again.
write 750, and Joni, if they come up with 650 or
Our
750,
sheet-
just write 750.
Yeah, shouldn't it be 1,000?
No,
If we have 50 milliliters
50,
per
5 times
centimeter,
15 is 750, 75.
5 times 17,
5 times, 15 times 5 is 75.
what are you getting,
I
15?
think they use 20.
You're supposed,
We're using
why'd you
20,
use 20?
10 to 20.
Oh, 20, we only used 15.
Well, I'm doing what
Thank
the chart
you.
says.
Well, that's
What is
I was
it?
fine.
wondering why you're saying 750.
Yeah,
Sorry.
we did 15.
Okay, 750 was throwing me off.
And what's the flow supposed to be at? 30.
Okay,
Sorry, guys.
all right, so we're doing 10 and 20. So 20 times 50 milliliters per centimeter blood
Should be
pressure
1,000.
is
Yeah.
1,000.
Okay, ready to
So
go?
we were a little
1,
high, right?
we gotta do it again.
But let's do it
1,
again and tell me if you see it
Well.
exactly at 20. You don't have to do the time, you got it.
One.
I want to make sure we have the right pressure
One.
set. Is it a little higher than probably?
ready?
So a little
1,
bit over 20.
2, go.
Okay, so let me decrease this just a tad. Okay, let's try it again.
And just give or take, just say.
Yeah, I just didn't want 1,200, that was too much.
Because I can't even get up there.
I was getting to 1,200. Okay, so
Mine
I'm
has
almost
taken
there,
forever
guys.
and a day.
Tell me what this manometer is and I'll look here.
Okay, we're gonna do it one more time.
Should be getting to
Okay,
20.
and then, I think I have to go up on my flow a little. Okay, ready to roll?
Is it 20?
1,
Yeah,
2,
we're perfect.
sorry.
So that gives you
Love IPDB.
Okay, so right down here, I'm still trying to.
Love it. I love it when a plan flies like it should. Okay, ready, set,
I'm
go.
gonna do it again so you see it.
Where do you
You have to measure it.
Yes, it's going great. Okay, all right, ready? 1, 2,
Go.
3. What's
Was how
wrong
much?
with you?
I'll just a smidge.
1, 2, 3, go.
We're on a race.
Yeah, mine's not behaving. See, there's just
1,000.
good.
Okay, so write down 1,000 for
Very
the
good,
20. And you can tell me how much that volume by calculating, right? There's lines. And then we just measure it. So 1,000.
Come on, kick
And
off.
what's the TI?
Kick off. Okay, it's 950, put 1,000 down.
7.7.
Because that'll make
with the
sense with the
same flow.
compliance.
So
How many
right on the
seconds did
outside
you
of your
get?
box, write 30
Good.
liters and 30
22
liters, so you know
seconds.
that flow's
So,
not changed.
Yes, that's what I was gonna tell them to
30
do.
liters and 30 liters.
So right here, I want you to circle it right to yourself.
Okay, so
When
you know
I
the
increase
flow did
pressure,
not
it increases TI and
So if you're going
volume.
from
And
here
then
to
answer
Upper
the
Marble
questions.
at 30 miles per hour.
You guys,
And you
you
get
can
there
sit in your seats and
in
answer the
4
questions.
seconds, right? Is it gonna be the same time if you go from here to St. Mary's with 30 miles per hour? Is it gonna take you longer?
just answer those couple of questions,
Your speed,
Okay.
it's gonna take
all right,
much
and then we'll do
longer.
flow and time.
Did it take us longer to get to that target destination? You went from 4 seconds to 7.7 seconds. So it definitely took you longer to get to the further destination. Make sense?
It's increased, right?
Yeah.
Okay,
it's
so you
increased.
see, when you don't change the flow, you keep the same flow, and you keep the same pressure, or you increase your pressure, something's gonna
Okay,
shift.
first
It's gonna take
question, what
longer
occurs to tidal volume
time
as pressure is
to get to that
increased?
pressure,
Increases.
'cause you've
Just
increased
put
the
an
pressure.
arrow, it goes up,
Mhm.
right. What occurs to inspiratory time as
If you
pressure
wanted
is
to keep
increased?
the same
Increases.
time.
Good. What occurs
As it
to the
took you to
time
get to St.
allowed
Mary's,
for
I mean, up and
exhalation
versus
as the
St.
pressure
Mary's.
limit is
If you wanted to
increased?
get there in the same
It's gonna
time,
decrease.
That's
what would you
right.
have to do to
Does
flow?
that make sense to you guys? If you have a longer I time, you'll have a shorter E time.
okay? That
Make sense?
Yeah.
Okay, all right.
Okay.
Now,
So
why would you
read
expect a
these
change in
questions and
TI
answer them to me.
because of an increase in pressure limit? Now, this is what I'm gonna have to explain to you. It takes a
That's the first
longer
answer.
time for alveolar pressure
Huh?
to match
increased?
mouth pressure, to equalize with mouth pressure.
Yep, that sounds
That's why it takes a longer time. If you increase
Yeah.
the pressure limit, it takes a longer time for mouth pressure, which is the pressure on the machine, to equilibrate with alveolar pressure. That's the answer.
What increased, what increased the
Okay.
time? Right, the TI increased.
So the only reason that that will pressure cycle is when the pressure equalizes between mouth and alveoli. If you increase the pressure, it takes a longer time for the pressures to equalize. Okay.
Exhale time.
The mouth pressure is considered that whatever pressure we have dialed in.
Longer to get there.
The alveolar pressure goes up as that volume goes in and that flow goes in. Does that make sense to you guys?
Okay, so if you
Yeah.
have,
Okay?
let's just put it
You
this
gonna
way,
say that again?
3
Okay,
seconds,
so
inhale and
we
exhale.
have a pressure
3
set
seconds.
at
And
15
initially,
at
it
the
took you
mouth.
1
At the
second to
mouth.
get
The
that
alveolar
pressure.
pressure is 0.
2
Okay.
seconds
When
to
that
get it
machine
out.
turns on,
You
you
still
got
have that
15
same
up
3
here,
seconds.
0 here,
And
but
now,
as the flow
I
goes
increase
in
my inspiratory
and the
time
lungs expand, the pressure in
2
the
seconds.
alveoli
So I have less time to
becomes
exhale.
more
Become more-
positive. When the
Because total
alveolar
3
pressure
seconds.
equals
Inspiratory
15
is now
as compared to
longer.
the
Do I have
mouth,
shorter expiratory
the
time?
pressure limit
Yes, so
cycles.
expiratory time
Okay.
Okay.
decreases.
So that means, yeah, it stops.
Does that make
It
sense,
stops.
Jordan?
So pressure does not, flow does
So
not,
always
will
inspiratory
continue to
time
go in
increases,
until the
expiratory time
pressure you have
decreases.
dialed in, which is the mouth pressure, the pressure at the mouth, as soon as that machine
Within
turns
a
on,
breath
when it
cycle.
equalizes with the
Make
pressure in the alveoli, the breath stops. Make sense? So that's the answer. Why does it take longer? Because it takes longer for the pressures to equalize now between mouth and alveoli. Okay,
Okay.
that's a concept that's hard to get, so that's why I'm telling you what that is right now.
Inspiratory pressure limit.
Now, this question I kinda asked you guys before. Okay, here, turn this over, because that's the question. Oh, where is that oh, okay, you're just on a different page. You're on a,
Maintaining the same flow rate.
yeah, I see.
Throughout the
Mine's on the
maintaining
next
same
page,
flow
so you
rate.
got that.
Okay.
Make sense?
It's gonna take a
Did you
longer
write
time
that
to reach
answer down in
pressure.
there,
Yeah.
Henry?
Yeah, I do.
And- Okay, everything with ventilation is mouth pressure. The breath doesn't stop until the
And you
mouth
reach
and
that
alveolar pressure equalize, okay? If you, when you increase the pressure, if you wanna keep the same amount of
When
time,
the pressure
if you
equalizes
didn't want it to
between
take
mouth and
22
alveoli.
seconds and
That's
you
like
wanna
the
go
thought.
back to
When you're pushing in
3.85
20
seconds,
centimeters
okay?
and the 20 centimeters gets into
If
the
you
alveoli, so
increased
pressure,
this
what you
and it
said
took
here, is
22
equal into
seconds,
the
but you
alveoli,
wanted
so
it to
mouth
go
and
in
alveoli
at
are equal
3.85
pressure. That's when it
seconds,
stops.
what
That's
would you
when it
have to
senses,
do?
oh, it's reached
That
that
has to do
pressure,
the flow
and
rate.
it's
You'd
gonna
have
cut
to
off.
increase the flow
Make
rate.
sense?
Turn the page, that's the
Okay.
next question, okay?
As the pressure
So these
limit is
labs are built to
increased,
do an
how would you
activity
be
and
able
then
to
it
maintain
asks
a
you
constant
questions.
TI?
When does the
You just said
IPPB
that.
machine cycle into expiration?
When the pressure is met,
When the, which pressure?
Does that
the
everybody
pressure
agree with
set
that?
by the
The
machine.
set, that's right, when the set pressure is reached. You're still up here, you didn't answer that.
You don't
I thought that was
understand
real.
that? Okay, so.
Yes,
I
but then what's
want
this question?
Jamie Lola to
As the
explain to
pressure limit is
Laura
increased,
why
how would
the
you be
answer is
able to
increase the flow
maintain a
rate.
constant inspiratory time? You would increase the flow rate.
Okay?
Does that make sense? If you wanted to maintain that 3.85, you would increase the flow rate. Because we didn't, it took a lot longer for the gas to go into the patient, right? Okay. So,
Say it again, when does the IPP,
Okay?
when does the IPPB cycle?
Go.
In other words, when does it turn off?
So
When the
if you're
pressure
going
you set is
from
met.
here.
Right, and
there are
that's
no
what Henry
scenarios.
just
If
said,
you're
when the
going from
set
here to
pressure is
Borough,
met,
Okay?
okay?
That's one distance.
If the
that's one
IPPB
pressure.
were never to
You're going
cycle
from
into
here to Borough,
exhalation, what's
and
the
it
most
takes you
likely
30 minutes
cause?
to get there.
Sensitivity?
The what?
Now you gotta
sensitivity?
go from here to Baltimore.
No, so in
You
other
have to
words,
do it
it's
in 30
going, it turned
minutes.
on, and it just keeps
What do
going,
you
so
have to
come
do
here and look
to
at
get
this.
to Baltimore in 30 minutes?
Let's say this line popped off.
What do you have to do to the gas pedal? What do you have to increase your speed, right?
Turned
The
on,
speed is the
correct?
flow rate.
Is the pressure
So
going
if
up?
you wanna go a further distance.
No, because there's a
which is
leak in
going
the
from
system. I
Here,
have to-
a further distance is
So
going
I'm
from a pressure of
stimulating
10
either the
to a
patient
pressure of 20.
lips not tight around the mouth
If we wanna go
or
a further distance.
something has come
we
off.
must
Here's another
increase
example.
Our speed.
See, the pressure goes up a little bit,
Okay,
but it's
which is
not,
increased, so we have to
it's
increase
just
our
sitting there,
flow
because I have a
rate
leak in the
to
system,
get
I
there
have
in
to
the same
plug
time.
the leak.
Okay.
And that's your
Okay?
TI. That's
So
your
if it
flow time.
stays on,
Something's gotta give.
there's a
We gotta
leak
increase
somewhere
your
in the
flow rate.
system, either in the line
I
or the
like your
patient's
English
not
flag.
keeping their mouth tight around the
Mhm.
mouthpiece.
Is that-
So you have a
the
leak.
English flag, right? I like it.
When you're studying for quizzes
Oh, is
and
she?
exams,
Oh, that's
you
cool.
wanna look at your lab
Okay.
workbook, cause that helps,
All right.
okay?
So.
So how would you
next one. When
decrease
does
the volume
IPPB
delivered to a
machine
patient
cycle
receiving
into
IPPB?
expiration? So
By
when does it
decreasing the
turn
pressure?
off?
Decrease the
Look at
pressure,
this, and
right?
You tell me when it turns
Okay.
off. When does the
Damn
cycle off?
thing's turning on by itself again. Oh, no, that's Joni. Okay. Okay, so we know the relationship between pressure and time. If you increase the pressure, it takes a longer time for the breath to go in. If you increase the pressure, you're gonna get more volume, right? Okay, so now what are we gonna compare?
Okay.
Flow and time?
Flow and time, okay? So what are we looking for? If we slow the flow down, is the TI gonna get longer?
Yes.
If we slow the flow down, will the tidal volume change?
No.
It shouldn't, because we haven't changed the set pressure. Good, okay, so let's come over here. So, what occurs, we can answer the question, what occurs to the TI as you decrease inspiratory flow?
No, so I never
It
reach that
should go
preset
down,
pressure of
right?
20, 'cause there's a
Okay,
leak.
I mean, it should go
You have
up,
patients
the
with
TI.
leaks around the
Okay.
mouth,
All right,
they don't
TI
have a
is
tight
time, right?
seal on
Yeah.
it, and then they never reach the pressure.
so let's take a
The
look and
pressure
see what
doesn't
happens.
equalize between the mouth and the
All right.
alveoli.
Okay,
So it does not
so we have it
turn
set at
off.
35, right? Set at 35, right?
Where?
Okay,
There's a leak
I
somewhere
mean,
in the
we're,
system.
the flow rate is set at 35 right
Okay.
here, okay? And then the
How would you
pressure is
decrease
set
the
at
volume
15,
delivered to the patient
okay?
receiving IP?
With the pressure set at 15 and the compliance still 50, how much volume should we be able to put in?
So you decrease the pressure. Everybody go with that?
Think, what'd you say?
Let's move on.
525?
Flow
No,
and time.
15 times 5,
So we just looked at, pressure and time.
75, about
Right.
750, okay? So we're a little
Now we're
slightly
gonna look
off
at
here.
flow and time.
Okay,
So,
all
we
right.
initially set the
Okay,
pressure
who's
limit
looking at volume?
to
And who's doing
15.
time?
Okay.
Okay, all right,
So,
okay. All right, you see where you're gonna look, you see the arrow?
This one right?
Yeah,
Flow
every
rate
line
is
is 100?
35.
Okay, so let's,
okay, so
Ready,
let's measure
set,
it to make sure
go.
we're at 15. Okay? How
do it
many
again,
goes to
Henry?
15?
ready, set, go.
It was past it?
550?
550? Boy, mine's really off, hold on. Oh, what did it go? To this one right here?
Above the, yeah.
Above the, okay, so that's 600, but we're gonna write 750. We're gonna write 750, because I gotta type
Is that
right
better?
this.
Okay, 15 is 35, I'm on 35 liters per minute, okay? So now,
Whoa.
what should the exhale throttle volume be with a compliance of 50 milliliters per centimeter water pressure? Would it, huh? 50 milliliters per centimeter water pressure, which is 0.05 liters, right? So 50
Good.
milliliters per
So
centimeter
what was the
water
first
you expect?
pretend it's a patient's lungs
Oh,
and to be able to change compliance.
750
Okay, give me
milliliters.
another reading, Henry.
So you could write on here per compliance, just so you guys can, if you're looking back at this.
Does that look more like 700 or a little more?
Per compliance is 50 milliliters per centimeter of water pressure.
Yeah.
Okay, good, let's say 750. What are we getting for time?
3.14.
3.14?
You should deliver
3.14,
a
okay?
tidal volume.
All right, you ready to go?
750
We're gonna slow
milliliters.
down the flow.
So that you can
Ready?
remember how you
Ready.
did that.
Ready, set,
We're gonna
go.
multiply 50 times
Hope
the
this
pressure
works.
set. On here, you can write multiply 50 times the pressure set, or 50 times the compliance. 50 compliance times pressure set. It's good to write notes, so when you're going back, you might not remember, you can review your notes. Okay?
700.
Does that make sense?
700, okay, let's say
Always
750, how long was the
What
TI?
volume should you deliver with this compliance and this
Good,
pressure set?
okay, so when we decrease flow,
So
what
we've got
happens to eye
15,
time?
we've got 35.
Say it again.
So
What
let's
happens
look
to
at
eye time when we
exhale
decrease
tidal
flow?
volumes. Now we're looking at
Decrease.
flow.
What happens to
and
tidal
time.
volume?
Flow
Why is
rate
it
of
the same?
35, we're gonna look at exhale tidal
Because we set
volume.
up
Because we haven't changed the
And
pressure,
the
time,
pressure. Oh,
okay?
yeah.
right?
Rhoda,
We
you're
haven't
gonna be
changed the
paying
pressure,
attention?
okay.
So should
All
we
right.
still put 750 or 700?
No, put 750 because I don't want, because technically it shouldn't have
What was
changed. We
that?
should be getting 750.
Okay.
There's, little glitches here and there. Joni, have them make up numbers, but always run the same.
It was 22.
Like in other words, we got 700, with that compliance, it should be 750.
Yeah, yeah.
And if they're getting a slightly different
What
tidal
did we
volume,
get?
when you drop the flow, keep it the same. So
Yeah.
then when they look, yeah.
What did
Okay,
you
so
get?
so now we can answer your questions. What are the questions?
Do it again.
What occurred to the
BT as we decrease the respiratory flow,
Okay, what did?
it stayed the same.
I was
Okay.
a little bit eight. so
What
let's
occurred
go
to the
just
tidal
a
volume as you
tad bit
decrease?
now.
Oh, wait a minute, is that the one we're on?
Yeah.
Okay, what
You
occurred
tell
to
me,
the
is that
tidal
50?
volume as you decrease the flow?
I wanna get
It stays the
750. 750.
Did the tidal volume
Look better? Was that
change?
15?
no,
No.
stay the
So
same.
Stay the same, why?
Okay.
Because
Because
what
Alright,
if,
so
change
35
pressure.
liters
That's
flow
right,
rate.
because the set
That's just
pressure
how
didn't
fast you
change.
get there.
Very
That's all
good.
that is. And the pressure is how
With the
far you
use
get,
of a
right?
slow inspiratory
The time is
flow
how long
rate,
does it take to
increase or
get there?
decrease the rate at which
Okay.
pressure is met.
So
So a fast
You could write
inspiratory
that
flow
down if
rate
you'd
is
like.
turbulent.
pressure
A
is
slow inspiratory
how far
flow
you
rate is
go.
laminar. So which one would the pressure be met
Pressure is
sooner?
how far you
Turbulent
go.
or laminar?
Turbulent.
Turbulent, so a
Slow
slower
rate is
flow
how fast you
decreases
get
the rate at
there.
which pressure is met.
Okay.
And that made sense, because it took much longer,
and
right?
time, is
Say
that
it
the
again.
last one? How long it takes
So
to
a
get
fast flow causes turbulence. A
Uh-huh.
slow flow is more laminar. So
Okay, these notes will
the
help you
rate
with
at
future
which the
adjustments.
pressure is equalized takes longer with a slower, more laminar flow,
Okay,
okay?
so exhale tidal volume, everybody write down,
So
750
the question
So-
is, which,
So,
milliliters.
so would using a slow inspiratory flow rate increase or decrease the rate at which pressure is met? It decreases the rate at which pressure is met. It's much
1.17.
slower, it's not as fast. Why would you expect the change in TI produced with a reduced flow rate?
It's pressure changing.
Okay, so now,
takes a
we're changing
longer
the flow
time
rate
for
from
pressures to
35 to
equalize.
20.
Okay?
Are we gonna get
Because
the
you're
same
going much
volume
slower.
if we change the flow rate?
Doesn't that make sense?
Yeah.
We're gonna get
Okay?
down to 20.
Always think of equalization. Did you guys mark that down? Okay. If you were to increase
So
the
all we
inspiratory
changed
flow
was the
rate
flow
on the
rate. Did we
IPPD
change the
machine, what
pressure?
would happen to the TI?
No, pressure's still 15, right?
It will be.
So is my distance the same?
Say it again?
It's gonna decrease.
It's gonna decrease, just like if you
Pressure's
put a
the
gas
distance,
pedal
right?
on,
So I didn't change
faster on
my
a gas
distance.
car, your time to get
So
someplace
should
goes
my volume
down.
be the same?
Okay?
I didn't change my distance.
And when you think about pressure
If I'm going
equalizing and
tomorrow,
fast
that's the
flow
volume,
rates,
right?
stick your
Going
head out the
tomorrow.
window of a
I
car
didn't
when you're
change
going
that
slow.
pressure or the distance.
Stick your head out the
So should
window
my
when you're
volume
going
stay the
65
same?
miles an hour.
yeah.
You know, it's like, whoa, what just happened
Yes,
there,
it should
right?
stay the same.
Okay,
Okay,
so
I didn't tell
if
you
you
that
were
I'm
to
increasing
increase
pressure,
the
I'm
flow
going to
rate on
volume.
the
I'm
IPPD
keeping my
machine,
same
what would happen
endpoint.
to tidal
So
volume?
my volume should change this, it should be the
Tidal
same.
volume.
It should
Stay the
still stay the
same.
same.
If you
Volume
increase the
is the
flow
same.
rate,
Yeah.
the
So,
tidal
what
volume
did
should
we
stay the
do?
same.
We
So-
decreased
So,
how fast we get there. Okay, so the distance
in
is
other
the
words,
same, but we're decreasing our
the
flow
end
rate.
thing
So
doesn't
pulling off
change.
the
If
speed
you're
pedal.
driving to
We're
Upper
slowing
Marlboro
down.
and you're going
Is it gonna
80
take you
miles an
longer
hour,
to get
you'll
to
get there
Laurel?
sooner, but where you're going
You're going
doesn't
the same
change.
distance.
And if you
But you're
slow
slowing down your
down, it would
speed
take
from 50
longer to
miles an
get
hour
there,
to
but
20,
where you're going
which is
doesn't
that.
change, so the
35
volume
miles an hour,
remains
20
the
miles an
same,
hour.
okay?
So is it gonna
Does that
take
make
you
sense?
longer to get there?
Okay. Would the
Yes.
use of a
So,
fast flow rate
exhale
increase
volume
or
for 20
decrease the
liters per
rate
minute.
at which pressure is
Put
generated?
750.
I think that
Yes.
Your
was,
TI,
That's the other way
well,
around.
let's do it.
with the use of
So
a
you know
fast
it's
flow
gonna be
rate. So if I
longer
stuck my head out a
because
window
you're
going
slowing down your
95 miles
gas
an
pedal.
hour, would the, I guess I wanna say would the pressure equalize, would I feel like a lot of pressure? Okay, so the pressure equalizes faster with more turbulent flow rate.
So we're still going the same distance, we're just going there, it's taking us longer, we slowed down our gas pedal.
Oh,
So
yeah,
how long did it
Patrick,
take to
hi.
get there?
Where are you, in the front of the building?
So right 9.82.
Okay, I'll meet you at the front doors, okay?
So it took us twice as
Okay.
long to
Okay,
get
bye.
there because we really
Okay.
slowed our speed
So,
down.
what's our
Took us twice
next
as long to
couple
get
of
there.
questions? Sensitivity. Can you answer those questions? And I have to let somebody in the door, and then we're gonna do resistance and compliance, and then we are done with IBED. Okay? All right.
Okay, so now we have questions. Okay,
What was the last
you
one?
guys, y'all three should work
increase,
together in
it's
answering
because it
these
equalizes
questions.
faster.
You three should work
Oh,
together in
okay.
answering these questions. So you
Is it
three
the last
talk
one
out.
that she asked?
Yeah.
This next is so irritating. I think the patient should ask questions.
How does it trigger inspiration? When it goes back, when the needle goes back?
I was gonna put pressure. I
Right.
don't know though.
When there's a negative pressure? Is that what you mean?
-2 pressure, right?
Uh-huh.
So you're gonna put pressure or negative pressure?
Yeah, negative pressure. The appropriate sensitivity.
I actually don't know, cause she was saying just reference numbers,
Oh, yeah, yeah.
so she
You
wasn't
three
really.
too, talk it out together so you all are on the same page.
She wasn't really specific on which number it was which.
I think that's the one that's a -1 to -2 centimeters.
Oh,
I'm pretty sure that's
but doesn't have to do with the pressure manometer?
Yeah. But I guess,
Say that again.
for this question, what is the appropriate sensitivity used for IPPB?
IPPB,
I was thinking that's a
Appropriate.
-1 or -2, but she did say.
yeah, probably -2.
For the, yeah, cause I remember she said.
Yeah, we see what we're talking about there.
And then
What she
we-
used for, okay.
We plugged in, so I'll
Yeah,
set
she
it up
said
over
-1
here.
to -2.
Yeah. Patient's room, diminished IPP.
It's not that
With
one?
the neutral and normal setting, you find the sensitivity set at -10.
Oh.
What would the setting require of a patient?
I
It would
don't know
rec-
anything about the sensitivity. Okay, yeah, so patient.
No, these are the only three we have.
It will require him to,
Breathe more or
And you, there are two of them. You set
have to
two
draw
of them.
longer, like work harder to,
yeah,
okay.
maybe use his accessory muscles?
Mm-hmm.
Huh? This is your muscles?
Yeah, like use his
'Cause-
accessory muscles because,
-10 is like far from -1 to 2.
yeah.
So you probably have.
Yeah, sure. Okay, to get answers? You guys working on sensitivity?
Yes.
Oh, okay,
So
okay.
it says, how does the patient trigger inspiration when using the IPPB?
Mm-hmm.
So we said negative pressure?
Yes, they dropped the pressure from the baseline. Perfect. So you can, yeah, that's good. What is the appropriate sensitivity setting?
-1 to 2?
Yep,
Okay.
okay, and you go into a patient's room, and you're gonna give albuterol and normal saline, in the IPPB and you find the sensitivity set on -10. What would this setting require of the patient?
To use his accessory muscles?
Yes, to turn on the machine. Very hard to turn on the machine. Makes
Yeah.
sense to everybody? Everybody in agreement on that?
Yeah.
If it was set at -10, so the patient had to draw back to -10
Mhm.
before it would turn on, does that make it harder for him?
Yes.
Yeah.
So it would increase his work of breathing, be harder for him to turn on the machine. If you were not noticing the sensitivity was set at -10, and you looked at the machine, what would the machine manometer be doing?
It will be going back and forth?
It would be, yeah, it would swing back when he tried to breathe to 10, okay, wouldn't be turning on until he hit the 10, and then it would go back when he exhaled, and then swing back again when he's taking a breath. So the manometer would swing more negative if he's trying to take a breath. Does that make sense? The manometer is this, guys.
Wait 1 second.
So it would be going back here and not turning on. So if you didn't notice the setting here, and you looked at this, you would
What's the
see this
answer for the
be
first
pulling back past -2 and
Yeah,
not
Greece
turning
is
on.
good. Second one?
If you were to notice the patient, what would you
Good.
notice?
Respiratory stress or accessory muscles being?
Accessory muscles, inspiratory accessory
So,
muscles, trying to
Would
get
you
that
use
thing
a
to turn
slow
on.
inspiratory flow?
Make sense?
Increase or decrease?
Okay.
Would
If
the
the
use of a
sensitivity were
slow
set at
inspiratory
minus
flow increase or
0.5,
decrease the rate
what
at
might
which the pressure
occur?
is generated?
He would hyper-oxygenate or
So
too much?
slow-
Hyperventilate, but yes, he
Slow
would.
flow decreases
What would
the
happen
rate
is
at which
it
the
would be
pressure is generated.
auto-triggering. In other words, not triggered
Because
by the
it's gonna
patient,
take
it would just be
longer to
triggering
use
by
that
itself.
pressure, right?
Auto-triggering.
So a
Does
slower
these
flow-
questions make sense to all
First
three of
off,
you?
And just talking about flow,
Yes.
if you
Yes,
slow flow
Patea?
down, it's a laminar flow.
Go ahead, ask.
Smoother.
Now is the time.
If you speed
Yeah.
flow up,
Auto-trigger
It's a
means,
turbulent
so if it was set so that
turbulent, and
the
you can
patient
actually
only
reach pressure
had,
faster.
if
Because it's
the
turbulent.
patient only had
Okay.
to draw back
So a slower
to
flow takes
minus
longer
0.5
to
instead of
reach
-1
that
or -2,
pressure.
could
Does that
that
make
machine
sense?
turn on by itself?
Yeah.
It could auto-trigger and turn on
Why would you
without the
expect a change
patient
in
trying to
flow?
turn it on. So you don't wanna be too sensitive, but you don't wanna be not sensitive
Right.
enough. That's why -1 to -2 is not a lot of pressure to generate, and that's the right pressure. If it's set higher than that, the patient has to really work to try and get it to turn on. If it's set lower than that, you have the possibility of an unintentional turn on, because it's too sensitive. Oh, Patrick, what's wrong?
Okay, and that's all.
So she's basically saying minus 0.5 is like too small.
Yeah,
Yeah, too sensitive.
Okay, yeah.
not between the -1 and -2 range.
So the
And
old
what?
machine, do you, can you
Okay,
tell
so
me
it says, if you were to increase the inspiratory flow rate,
Oh,
what determines the distance?
so these two are the newer ones?
Distance is determined by what?
Okay.
The preset pressure you set. With that preset pressure, does it always meet that pressure?
I only,
Is it always gonna meet that pressure? It will always meet that pressure, no matter how what flow you have set. It's gonna always meet that pressure, so will it give you the same color volume if you never touch pressure?
Okay. Is wrong.
It should,
Okay, so
unless you
we
have,
tell something higher up?
unless you have an increased resistance. That's adding in something different.
Okay.
Right? Whenever you
that's
take that
okay.
pressure, so if you have the same conditions,
Okay,
no wheezing
all right.
or anything like that, it gives the
now
same
we're gonna
physiological
check compliance and
conditions.
resistance. So we already decided,
That
at the same pressure, if we
being met, whether
decrease
it's
compliance,
sooner
what
or
happens to
later,
tidal volume?
That same volume's gonna be
Same.
delivered,
Huh?
right?
It's Stacy.
So
Same.
it doesn't change.
Guys, same pressure, but suddenly the compliance goes down.
Oh, it applies down. It decreased.
Would it,
It would have, if I had a compliance of 50 milliliters per centimeter of water pressure and dropped it to 20 milliliters, that's telling you now, for every centimeter of pressure, I'm only gonna get in 20 mils of volume.
increase the flow rate.
So what's gonna happen to
you're
volume if
pushing
somebody's
further gas on
compliance
the
goes
pedal,
down?
Right,
Decrease.
you're pushing
Gonna
that pedal
increase,
down
right?
faster.
Tidal
So
volume,
you're
if
increasing your
compliance
speed.
goes down,
Decrease.
you,
It goes
if
down.
they're
Because if you were
stiffer,
to increase
you're
your
not gonna be
speed
able to
or
get the same
inspiratory flow
volume.
rate in an
So if you had a
IPG,
compliance
what
of
would occur to the
50
TI?
milliliters, Write that down as I'm talking. Compliance is 50 mils per centimeter of water
So the
pressure,
PI is gonna decrease.
and the pressure is 10 that you set.
So think about it like that. when
How
you're-
much tidal volume can get in?
So you can kind of answer these questions, because you'll have questions.
If
like that.
compliance 50.
Compliance is 50
Okay.
mils per centimeter of water
that good?
pressure, and your set
Okay,
pressure
now,
is 10.
If
500.
you have added
500.
physiological
Does that make
Yeah.
sense to everybody?
Mhm.
Now the
Let's say.
compliance suddenly
So we
changes
said
because
if you have
he
a certain pressure,
develops a
it's gonna
mucus
deliver
plug
that certain
and
volume.
part of the lung
As long as
collapses.
you have the
And the
same
compliance goes
physiological
down to
conditions.
20
So let's say
milliliters per
airway
centimeter of
resistance
pressure.
goes up.
And the
Mhm.
pressure is still
Starts
10?
wheezing.
So pressure's still
And
10.
before they were wheezing, a pressure of 20
Yeah,
was
so
giving
what
a
happened when
tidal volume
compliance
of
dropped
500,
if the pressure stayed the same?
Okay, now they're
It
wheezing.
decreases.
The
Decreases the tidal
The
volume.
tidal
If
volume.
you wanted to maintain the same tidal
Because
volume,
there's
what
resistance
would
in
you
the
have to
airways.
do?
So that pressure
Increase the
going in,
pressure?
if
That's
you're gonna
right.
meet that
That's
pressure
right.
sooner, you will,
If you hold on to these,
okay? When you have
as we move
decreased
through mechanical
resistance,
ventilation,
you're gonna reach
you
that
will have,
pressure
a-
fast,
this is what the,
quicker.
this is what the basics
Okay.
are, relationships between
Because of
things. All right, so let's
increased
take a
airway
look and
resistance.
prove it.
So you'll meet that pressure sooner, and your volume won't be as high.
So what's
Okay?
the flow
If
supposed to be,
Your compliance
guys?
worsens,
5.
you're
The
gonna meet
flow?
that pressure sooner
Oh, no.
also.
You gotta read the directions
volume
on
will be
activity
the same.
2.
It's only if you have normal physiological.
35, so
that
is it at 35?
Your pressure will always
Let's
yield
turn it to
you the
35.
same volume.
Okay,
Makes sense?
and we have,
Did you
now,
talk to
look
him
at
about
the-
resistance and compliance?
that's coming now. Yes,
Okay.
yes. You
I
mean
just-
in the
I just-
PowerPoint?
No, like right now.
Yeah, I just asked them, what do you think is gonna happen?
Yeah, that's
So,
what I
and then we're
asked
gonna
them.
prove it. Okay,
All right, so now we're gonna prove. what
this
we
is
just
a
discussed.
5 resistor,
Okay.
that's the airway.
It's kinda like, think about this.
This
If
is a
you're-
50
If you have a big
resistor.
tube, and you have 20 at pressure, look at me, if you have a big tube, and you have 20 at pressure, this pressure's going through. It's gonna get through easy. You're gonna make it all the way to the alveoli,
15.
okay? But all of a sudden now, I have a little tube, my airway's
So in
closed
which
up.
one will the
I have
pressures
same 20 at
equalize
pressure trying
faster?
to get through,
The small
that's
one?
gonna create
Yeah,
resistance,
the small one,
creating
they'll
back
equalize
pressure. You're
very
gonna reach
fast,
that
because
20
again, it's generating,
Sooner.
the
than if it was
pressure it
wide
has to
open.
generate to make it through there
Once
is
it reaches
high.
that 20, the machine
Okay.
turns off.
All right, so
So you won't have as much,
compliance
the flow, the
here,
pressure's
if
not
we're
getting
at
through, so
5,
your
and we're
volume
gonna
will be smaller.
decrease the compliance, we're
Does
gonna
that
make
make
it harder
sense?
to
So I
expand
want
the
you to
lung,
understand that
okay?
concept.
So right
before we do
now,
this next.
we keep our compliance the same, we're gonna change the
Okay.
resistors.
Sensitivity.
So I'm on a 5
That's right,
resistor
so we
right
need to
now.
talk about sensitivity
Okay.
next.
So.
Okay, so turn the
Okay.
page for me,
So-
Yorda, and we're gonna talk about
You
sensitivity.
guys want to manage the volume? Pataya, you manage turning
Right.
this on. Henry, you look at the volume. Sean, you calculate, and I'm not gonna mess
Oh,
around.
okay, start on
You wanna
sensitivity.
say to Sean, ready,
Okay.
set,
So
go.
what's the
So
first
she knows when to
question?
hit it.
Debbie Lola.
I should pull it, right?
Push it in,
Push it in.
but count. 1,
How does the
2,
patient
3.
Ready, set, go.
What is the trigger and IPV?
800? Okay, I'll take it, 800. Well, wait a minute. What's it
I
supposed to
told
be?
you
What's it
pressure,
supposed to be?
volume,
That's
flow,
five.
what's the trigger for IPV?
What are we doing? 50 mils per centimeter of water
Huh?
pressure?
Pressure, so you
50
gotta drop the
times,
pressure
what
back
is
to
it?
the
What are we
machine
setting the
to
pressure
kick
at?
on. So
Uh,
the drop in system
15.
pressure from
15?
baseline.
Okay, so it should be, you said 800? Just write
Yours is down
750.
here.
Okay?
You can say a drop in
So that I
system
don't
pressure
screw you
from
up with what I've been
baseline.
talking to you here about. So 750,
And the time is
800 close.
3.13 seconds.
what?
and the time was what?
3.13 seconds.
3.13 seconds. Okay, Henry, you're gonna change the resistor.
What is the
You're gonna
appropriate
put a
sensitivity to
50
use for
resistor
IPV?
on there.
3.1 what?
3.13 seconds.
And Henry, did you get the time down on that?
What'd you
Alright.
say, Yorda? Yeah, negative.
I'm gonna try
you're
and
setting
stand
those
back a
water
little bit,
pressure
so you guys
before you
get used
set
to
it.
changing resistors
-2.
and stuff like
You don't
that.
want them sucking back too much,
Oh,
that would
this is
create
the
a lot of
resistor,
work for them.
right?
That's
Just
the
a trigger and
resistor, so
breath,
we're
right?
simulating a
So
tiny airway now.
-2 is pretty much where we would set.
Ready, set, go.
You enter a patient's room
Right.
to administer
Wait,
IPV
something's
with
wrong.
albuterol and saline. If you find the
put a
sensitivity
50
signal negative
resistor on
10,
there?
is that gonna increase their work of breathing to try to pull,
I put a 50
try to
on there,
have
right?
breath delivered to
Hold on a
them?
second.
Negative 10, guys?
I got it.
So Daminola,
Oh,
if I put a mouthpiece in your mouth, and and I put the sensitivity at -2, and you have to pull back just -2 centimeters, just a little bit, and the machine triggers and gives you a breath, okay? Good. So now I turn it to -10 centimeters. So would you have to suck back harder to trigger that machine to turn on and give you a breath?
Okay.
You gotta suck
We're
in
gonna do
to
the
get
first one
that,
over
to
again
drop
right
that
after we
needle
do
to
this.
-10
Okay?
before that
Let's put
machine
the
will
5
turn on and
resistor
give
in
a
there
breath.
again. It should be
So
the
that's
same
a lot
volume,
more
just do the
work for the
timing for
patient,
me a
right?
little different. Okay,
So
trying
now
to get
what
this
is
to
this
work out
answer?
exactly for you guys. Okay, go ahead, do it again.
Ready, set, go. Oh,
It says, what would the settings require of the patient? What would it require of the patient?
set, go.
Oh, what the hell? What is going on?
If I set it at -10, what's the patient gonna have to do? Yeah, suck in harder, work harder to get the breath. Suck in harder to get the breath.
This thing is so touchy.
That's gonna tire them out, boy, if you do that to them.
That worked.
Are you reading the next question?
Okay, that worked, that worked. Okay, so do it again.
So the
Ready,
machine,
set,
what
go.
happens with the manometer?
800?
Okay, 1.8 and 800.
Goes in the
So
negative
let's put
side, there's a
1.8
negative
and
side and positive
750.
side, right? It will go back to -10,
1.8 and 750.
before the machine will kick on.
Now, let me do the
Does that make
50
sense, Yorla?
resistor. So we had 1.8
Yeah,
seconds
so
and
you look on that,
750. Ready to roll?
you see the pink
Ready,
side?
roll,
Yeah.
one,
That's the
two,
negative
go.
side, you see the green side?
Yeah.
That's the positive side. So if you have the sensitivity at -10, that needle
300?
has to go
How
back
many
to
seconds?
10.
1.44.
Yeah.
Negative
1.43, you wanna do it again?
Before the machine will kick on and give a
Okay.
breath.
Patea, let
We
her
don't
know.
want that, we want them only
Ready,
to
set,
give it
go.
on the inside of -2, so that they can get a breath easier.
1.05
trigger
and
a
how
breath.
much?
300?
300.
Okay,
So, hey Joni, I'm gonna tell you right now, the resistance one's a headache. You'll just have to play with it.
okay,
You might have to play with your flow rate a little bit so it works like it should.
okay. So what happens
Okay.
with the patient?
Got it? So what happened when we have increased airway resistance?
Yeah, so if you, what would they look like if they were increasing
Decrease
the breathing?
tidal volume.
Tidal volume, why did that happen?
Talk, using accessory muscles.
Talk
Here
about
we
in
go,
terms
right
of
there.
alveolar pressure and mouth
Increase use of
pressure. Do they
inspiratory
equalize
accessory
sooner or
muscles.
later?
Sooner.
Sooner. So this 15 is met much sooner. And so what happens is the volume goes down.
Decrease.
Next
Okay.
question, if
Okay.
sensitivity
Even if we
was set on
didn't change the
negative
pressure,
0.5
what happened was the
centimeters,
resistance
what would
caused
occur?
the pressures to equalize sooner. Okay, so we lost volume. So let's answer those questions. All right. Okay, so
Sensitivity.
what occurs to tidal volume as the resistance goes up?
It decreases because the pressure is equalized faster.
Yeah.
Hey,
What
Nina,
occur-
you didn't have, the students don't have this last question here?
Which one?
If the sensitivity were set on -0.5?
Oh, I guess they don't. My guys didn't tell me that.
Oh, we,
I wrote
They
it
must have
down.
been one,
Oh,
oh,
listen.
Henry
I
wrote it
wrote it
down.
down.
So we better, move a little bit faster through this if possible, because we
Alright.
gotta get to the BiPAP.
All right, so if it was
Okay.
-0.5.
So, sorry.
I could be.
So what happens if the sensitivity was, put it next to that
Okay.
little
And it
dot,
causes the
if the
hyperventilation.
sensitivity was set at minus 0.5, what would happen?
it auto triggers.
You know, on
Yeah.
a trigger, it was constantly.
The sensitivity is set at
constantly triggered,
0.5, what would
patient would
happen?
hyperventilate.
Just write that down. If sensitivity is set at 0.5, what would happen?
It's
Okay.
Auto trigger.
Auto trigger, yeah. Okay, all right, so,
Just to let you know, auto trigger just means it's constantly
okay,
triggering.
what occurs to the
It's gonna
exhale
cause them
volume as the resistance is increased? We said it decreases, right?
They don't-
What occurs to
they used
inspiratory
call it all
time
this
as
like
resistance
that.
goes
We don't
up?
call it that anymore. So in the hospital, you don't
Decrease.
hear that,
Yes, just look at your graph and see what you just did.
but it's-
Now,
but
why
it's
did it go
auto trigger.
down? It all
They
happens
say
to
all
do
the
with
same
that same
things.
thing I keep saying.
Just to let
The
you know.
pressure
We have different
equalized
terminology.
faster.
The pressure equalized
Different
much
things you
faster.
learn here and then
Yeah.
you practice.
Make sense to everybody?
You try to clarify.
And when you guys wanna say what pressure,
So let's
pressure
do this
between
quickly.
mouth and
So now we
alveoli,
have specific
Okay.
compliance, the simulator compliance is.
or the
0.05,
small
we have
airways,
that.
mouth and small airways
now we need
equalize much
adjust-
faster. What are
So we
three
need a
things
5.
that could cause increased airway resistance, guys?
Okay,
that have to do with the
resistance
patient?
changes. Initially set inspiratory
What
pressure
things could
15,
go in the
I have
airway?
that.
What things in the airway could cause increased airway resistance?
Increased mucus.
Mucus is one,
All right,
yeah.
resistance of 5, so we're looking at the
What
difference
else?
between resistance. With everything else is the same. right?
Inflammation,
We're
so
just gonna look what
swelling.
happens if you increase
Inflammation and
resistance.
swelling,
So
the
at
same
5,
thing.
what was our exhale tidal volume?
One
Let's
last
try it real
thing,
quick.
that could make an
Okay,
airway
I
narrow,
want you to do time, I need you to do tidal volume.
bronchoconstriction,
Okay, here
so
we go.
smooth muscles
We're
constricted.
at 5.
Are you getting all that, Pataya?
What was
Yeah, I
your
didn't get the
tidal
number
volume?
3.
Mucus,
No, the
Edema.
It should have been.
No,
or
no.
Seven
What would
fifty,
you,
right?
on
Wasn't
top of
that
the
what we
question,
did before?
question number 3.
Why would you
15,
expect the
just
change
write down
in tidal
750,
volume?
that's what it's
Yeah.
supposed to be. We already
It
figured that
decreases
out.
because
750,
pressure is
how long did it
equalized
take?
faster.
yeah, so the TI goes down.
Yeah, it should be the same as what we just
Right.
did. 4.1.
So the pressure limit is met much
should be
sooner,
exact
guys.
Same, right? We just did that. Now,
All
we're
right.
gonna increase the resistance. Can you find me a 50
What
resistor?
drug would you give during an IPPB treatment
I
to
want you to look at the
decrease
difference
airway
between the
resistance?
Here's a 5.
Give me any
Look at
kind
the
of
hole.
drug, that would
See the
decrease
hole?
airway
See the
resistance.
hole. Look at
If
the
you
hole.
give steroids,
This is a 50.
They take too long.
Okay, which
Inhaled
one has
steroids would
increased
take too long.
resistance?
What could you give in the
50.
nebulizer?
Am I gonna meet that
immediately
pressure
that
faster
would
with
have
that
an
tiny little
effect?
hole versus this big hole?
To
Yes, this
dilate
one I'm
the
gonna meet
airways.
resistance pressure much faster because it's a
Tiny
tiny
little-
orifice.
Come on,
Okay.
man.
What drug
I'll be
decreases,
prepared.
what
I'll-
drug
Have
decreases smooth
bronchospasm.
muscle
I'll-
constrictor?
Okay.
Constriction.
Now we're gonna put-
Albuterol?
Yeah, albuterol, any
Albuterol.
beta agonist.
5.
Right,
Yes.
right, okay,
Now we're
yay,
going to 50.
Pataya.
Okay,
Alright.
same
Okay,
flow,
now,
same
what
pressure.
objective measurement could
Okay,
you do
now
on
let's
the
see what
patient
happens.
that would let you know
Watch your
whether
breath.
he's able to exhale
What's
out
that tidal volume?
faster,
Okay, we're gonna do it
now that you
again.
bronchodilated
Ready?
him?
He is not in a
6.
tripod position. He doesn't look.
No, he looks
550.
good, his lungs are open, cause you gave him
Lee, did you
albuterol.
get 550? For
Huh?
50 resistance, did you get 550?
We have 300. Because I had to go up on my flow, there was no change on
Right.
my time, my TI.
Yeah.
So what I did
Does
was
that have to do with,
pick up
like,
my
the
flow rate.
peak
Just what did you get for the first one?
You got 754.1.
And what'd you get for the second?
You got
I think you can
600.
use that for
Okay, so 600 and what?
Maybe
was your
his the pressure
Oh, that's
would
good.
be would
Ours got all screwed up. Okay, so
What
that's good.
objective
All right, so let's do it
measure?
again.
you have less
Okay.
resistance. The
But if
time
you're-
will be met
but
sooner.
Oh,
my
the
feeling
time.
is if
Yeah,
your
the time will be
compliance
met
is still
sooner.
set the same,
Huh?
we should put
Maybe the
750
time will
up.
be met sooner.
Did they?
750's
Oh, yeah.
here.
Good. Okay.
Okay, ready?
All right, so,
Again.
what objective measurement could you do with the patient right after you give him a
Okay, so right,
bronchodilator that
550
says, yes, he can blow
And
out air
3.24.
faster at a better rate, flow rate?
Okay.
His tidal volume will be
So
met
this
sooner.
tells
Well, the
us
tidal
with
volume would
a
change
big
on the
increase in
IPPB, the tidal
resistance,
volume would do what
it'll
if
let
you
take
opened up
3
the airways?
seconds to
It'd
meet
increase.
that
It would
pressure to
increase,
heat.
but what little test do
When
you
had
go
no resistance, it took you 4 seconds
test whether
to get
somebody
meet that pressure.
can blow out air
15.
faster right after a
And that just
resistance?
means pressure
Spirometry?
What do we
equalizes
call
from-
it?
From here or the
Spirometry?
mouth to
A
the
what?
alveoli.
Oh, this
Okay.
spirometry.
Once it meets that
spirometer, peak
pressure,
flow.
no matter what the
Yeah.
volume is,
The
it's
peak
cutting
flow
off.
measurement. So there's two
This
things, you
We're
can do a
setting the
peak flow
pressure.
measurement,
Setting
and
it-
on the
we're like-
IPPB
we're like,
machine, the volume
setting, I
should
would
get
say, like
bigger
a
if you
computer.
open up the
You're
airways,
programming,
the
you're
exhaled
telling this
volume
machine
now.
to deliver
Does that make
15
sense to you
pressure,
guys?
No matter what,
Yeah.
it's gonna deliver
Yes.
15.
Yes?
If you have increased
Good.
resistance,
Okay.
you're gonna meet that pressure.
So now we're
sooner,
doing compliance,
Okay?
and then
because you're meeting it sooner,
we
you're not giving as much
can
volume.
take a quick break,
Makes sense?
get something quick to eat,
Okay.
if
So
you want
now,
to,
we did
and
that.
then
What
we're
if
gonna
there was
do
exhale
CPAP and
volume
BiPAP,
resistance is
okay?
increased?
So let's go over here, we already
volume
talked
increase.
about what would happen if we change compliance, if we go up on compliance, what happens
TI?
to volume?
The resistance is
If you're more compliant, what happens to volume?
Decrease.
It what?
Decrease.
It what?
Increases.
Oh, increases, good, okay. Now,
what would expect the
why
change in T-
does
Why?
it take,
tidal volume and
If the
TI produce
compliance.
with the increased resistance?
How-
Oh, yeah, I'm sorry, I was thinking the wrong way.
Right.
Sorry, I was thinking about the resistance.
yeah, no, if compliance increases, they're easier to
Yeah.
inflate.
Pressure
Yeah.
limit
And
is
it
met
doesn't,
sooner.
it takes longer to meet the preset pressure, volume goes up, because your lungs are easier to
What
expand.
are 3
So let's look at
causes
two
of increased airway
compliances.
resistance?
Okay, so let me turn this back to 35. So Henry or Patea, whoever, or Schoen, well, Schoen's our clock watcher.
Bronchospasms
Somebody
one.
change the compliance, and what you need to do when you're changing compliance, you unscrew here.
What else in the airways? Is
So
there-
you unscrew it slightly.
Yeah,
You take
secretions
your hands
too.
and you move it up
What else in the airways? What else happens in
and
the
or
airways to
down,
decrease that?
depending on where you want the
lumen?
compliance. So we want it at
Airway
0.08.
Inflammation.
In a perfect world, 15 centimeters of pressure would give us what volume?
Does that make sense?
0.08.
Okay, what drug do you administer with IPV? You
Point
can
zero
put
eight is
medication
the
in
same
here
as
to deliver
80 mils
a
per
drug.
centimeter of water
And
pressure.
that's gonna
We're
push
still
it into
using
the lungs.
15
What drug would you
centimeters of
administer
pressure.
if you had,
1,200.
It
increased
should be
airway
around
resistance?
1,200, 1,200, but
Okay,
our
specifically,
little
what's the
thing
name of
is
the
not
drug?
acting like we like it to
Albuterol.
act. Put the 5 resistor back. And then the resistor is going to the bag.
What objective measurement may be obtained to evaluate the effectiveness of this drug?
All right, we ready to go?
Yeah.
Batea?
Ready, set, go.
What'd you get,
Yeah,
Henry?
peak flow.
1,300?
1,300? That's close enough. Put
You
1,200.
get
What did you say it should be?
Peak flow.
Yeah, 1,200.
It should be 1,200, eight times
What else
5.
could you
No,
tell?
is
in
that right?
your,
80 times
resistance
15.
decrease
1,200?
Delivery.
Okay, all right.
And I.
Okay, how many seconds?
3.94.
3.94. Now, what are we gonna do to the lungs, everybody?
Just with looking at this.
What are we doing to the lungs?
If resistance
Tell Henry what he's
increase-
doing.
It's getting better, decrease,
He's
resistance
decreasing the
decreases.
compliance.
To what?
You get albuterol and your airways are opening
Zero
up again.
point zero three,
What
so,
could you
and you wanna
wanna
use
measure?
both the upper and
It's gonna
lower, so,
change.
oh, did you get it
They
there?
go from
So you're
constricted to way
unscrewing,
open.
and
What's
you're
gonna
move
change when
this
you're
up
giving
to make
15
it
centimeters
stiffer.
of pressure?
You have to hold the bottom of the spring and the top,
Huh?
and move it down to
still
30.
using
Pressure can't change, that's set,
resistor
that's
for
what you've
5,
set.
5, yeah.
You're the
'cause
programmer,
we're
you
going
set this computer to be 15 centimeters of water pressure, so that's
Which is
constant.
30 mils per
That does
centimeter
not
of water
change.
pressure. Do you see 0.03 there, Henry?
Yeah.
Okay, so you're gonna go up
The
to
flow
there.
rate's set.
So what do you
You
think our
set the
tidal
flow
volume is
rate
gonna
at
be
35,
now?
did that change?
450.
Yeah, boy.
Resistance
See how that
changed.
happens? And the pressure's gonna be
Resistance
met
went
much
way
sooner.
down.
Ready?
Yeah,
Ready,
So I'm gonna make my
set,
resistance
go.
go down and you tell me what changed. Can I have that 5 back? This is
300?
50.
300, do it again.
Ready, set, go.
3 times 15.
We
Is it
just did
300?
that.
Okay, so make it 450, just so that when you're
Okay,
looking
they
back
can
over this. So
300.
what happened to our volume, guys?
Let's give the same flow
That'll
rate,
decrease
same
the
pressure.
It
Every time it's
decreased,
What's gonna happen?
1.54.
so
Now
boy,
get the larger
and that all
volume, so
happened,
that'll
why?
tell you
Because the
that your
pressures equalize much
bronchodilator worked.
sooner
Resistance
with a
has gone
stiff
down.
lung. So volume goes down.
That makes
No
sense?
change in pressure, but the
Sometimes
volume
you
went
have to
down.
see it to get
Because
it.
you're stiffer. Does that make sense?
Yeah.
Okay, makes sense to you, Henry?
You said it?
Okay. What's the
The
next
lungs
thing?
get stiffer.
Now we're
when
looking at
compliance
volume
goes
and
down.
time.
Yes.
Pressure equalizes much
Okay,
sooner.
so what do we have to do?
So the pressure didn't change,
Set the lung simulator?
but the stiff lungs,
So when you
the
move this-
pressure was met much
this,
sooner, so the TI got
compliance here,
shorter and
You
the
have to
volume
move them
wasn't
both
as high.
together or it'll break.
So what you always have to
See what I'm
remember,
doing here?
COVID lungs,
So
they're
it's
like
0.08,
cement.
you just have to
They
move the
can't
top and the
handle it.
bottom together.
They end up using such high pressures, they take
Yup.
them off and then what they do
It's 80
is they have to
milliliters
take,
per
they do
centimeter
everything,
pressure.
take all the blood out of their body, oxygenate it, remove the CO2, put it back in, we can't ventilate them. Okay,
Okay,
so
I'm
stiff
setting
lungs, harder to ventilate.
See how I just moved the
Take
top and the
more
bottom?
pressure
It was
if
at
you want the same volume.
50 mils.
Okay, so
now
let's
it's at
look at the
80,
questions.
Or 0.08 liters, okay?
So, what occurs to the exhale
So
volume as
pressure
compliance
you're
goes
setting is what,
down?
15?
It
Decrease.
decreases.
Yeah.
So 15
So when you're
times
studying,
what?
when you're looking at your labs, you just
80, 15
prove
times 80 is
everything
what?
we talked about in
So
the
you should
lecture.
expect to deliver 1,200
It's just a
times
visual
what?
proof of, oh yeah, that does happen. Follow me? Okay, so, what occurs to the inspiratory time?
Decrease.
By the way,
decreases.
And
it's
why
just
is
normal
that? We
tidal
just kept
volume,
saying
some
it
of that.
again and again and again,
I mean,
because
normal-
pressure
Equalize faster.
between
The
mouth and
mouth-
alveoli met much
Equalize.
sooner.
Normal compliance is
Right.
what?
Now, here's the questions that I want you to think about,
80
because this
to
is
100
typical of
milliliters
something
per
on a
centimeter
test.
water pressure. That's normal compliance for someone not intubated.
You
So we
okay
have
there,
normal
Henry?
compliance
Yeah.
right
The
now?
pressure equalizes sooner,
Yes.
did you answer that?
Okay. When you're
Between
having
mouth and
tubing in,
alveoli?
If cuts in half.
With resistance, it's between mouth and the airways.
Normal cuts in half when you have tubing.
All right,
so we're at 15.
so we have a 70 kilogram
15,
patient. What is the
we're
first thing I
resistance
told
at
you
5.
when you see 70 kilograms
Okay, what
and they're
does it
not
say
giving you
first? Now
height?
we're looking
Assume
at
that's the
changes in
ideal body
volume
weight.
and
What kind of
time.
tidal volume do you want to
So
shoot
this
for?
is showing you compliance. What's your exhale tidal volume
You
should
said the
be?
volume should be 10 to
10 to
15.
15 mils per
Just write
kilo.
12
So right now on the
That's
side
where it should be.
there,
We'll
write
make
down
sure.
the tidal volume should be,
And let's see how long it takes. So let's
Between
get to
what and what?
1200 before we
Ten
For
do
70
time.
kg?
yes, right down here. For 70 kilos, right here, what should the
So
tidal
we're more
volume be?
compliant, so we can get more volume.
700 to
Make sense?
1500? No.
No,
More
No,
compliant,
700
you're not meeting that
15
pressure as
times
soon.
7
So you're getting more volume in.
is like 1,000
Does
something.
that make sense, your order? So 1200.
What do you got there,
That was good,
Sean?
right?
So
And
it's
now let's count the
700 to,
time.
I'm trying to do that down.
So 1200.
1,050?
the TI is
1,050. Okay, so you got that down. All right, so here we have a 70 kilogram patient unable to achieve adequate volumes on the incentive spirometry. The physician orders the patient to receive IPPB. Where would you initially set the pressure limit and how would you determine the final pressure setting?
Okay, so
I
right
told
now
you in
6.85.
lecture, you start
It
with
took
an initial
6.85
setting
seconds to
between
get
what and
in
what?
1200
2 to 5?
milliliter tidal volume.
No,
10 to 15.
10 to 15
Okay.
centimeters of pressure.
Now, we're gonna do a
That's the
compliance
initial.
of 0.03.
How do you titrate it? You
So I
just
take
told
this and I
me that.
move both 0.03.
So you start out
What
with
does
10.
0.03 mean?
How do you know you have to go to 15? What would tell you have to go to 15?
30 milliliters per centimeter water pressure, not
You go to the
300.
patient, you know
That
there's
means
70
it's 30
kilos, and you
milliliters
start
per
out the
centimeter of water
IPPB
pressure.
machine
For
with a
every
set pressure
centimeter
of 10.
water pressure, I can get in 30
What
milliliters.
would tell you you might have to
Okay?
go up
When
to
I was
15
at
or 12?
0.08, I could get in
If
80
the
milliliters for every
1,050
centimeter
isn't
water
met?
pressure.
If
Which one is better?
700 to 1,050 isn't met,
Huh?
any volume
0.08?
between those
Okay.
two is acceptable
So my
for that
compliance is
patient.
going down.
You're shooting for between
Now we're
10
gonna do
and
the same
15
thing.
milliliters
Do
per
you think we'll
kilogram
get the same
of
exhale
ideal
tidal
body
volume?
weight. So your
Why?
initial setting again for any patient, regardless
So
of
what
size,
happened?
is
Am I
10
delivering
to
the same
15.
pressure?
And then you calculate,
Pressure
you do it at
set.
10, you
So why
calculate
can't I get in
what
the same
is an
volume?
acceptable volume. Anything between 10 mils per kilo of ideal body weight or
Yeah,
15
what's-
mils per
what's
kilo
happening
of
with the
ideal
pressure?
body
Why am I
weight.
not
So
getting
when
the
you do it
same
with the
volume out of
patient
the
and you
same
measure the
pressure?
volume, if it's not at least 700,
It's not
increase
resistance,
the
it's
pressure.
compliance. That's the
try 12,
expandability of the lung.
and try 15.
So tell me
If
about
it
the
was
pressure.
over
It's hard to
1,050,
expand.
you would
gotta
have to
think about it.
decrease
Tight,
the
tight
pressure.
rubber bands.
Does that
So
make
it's hard to
sense?
expand that lung.
Okay, good.
That's the
So when you're
elastic.
asked on a
Hard to
test, what are the
expand.
initial
So is it gonna
settings?
take- am I gonna
It's
reach that
anywhere
pressure
from
sooner
10 to
if I'm
15
having a really
centimeters
hard
of
time
water
expanding
pressure,
this
and
lung?
you titrate it
Yeah, so I'm
in
gonna
order
raise the
to
pressure
achieve a
sooner.
volume between
Therefore,
10
I'm not gonna get all the volume in.
and 15 milliliters per kilogram.
make
And if we
sense?
give you the patient's
If you have a
size,
really
you have to just
floppy,
tell us what the tidal volume should be between. Does that make
You have a
sense?
really floppy.
Okay.
rubber
You are
band.
delivering
Okay. And I
IPPB
put
to
20
a
centimeters of
60
pressure
kilogram
in.
patient. Right away,
It's not
figure
gonna-
out what the volumes should
I'm not
be.
gonna reach that pressure
60
as fast.
kilograms. Do you
And
need a
it's gonna allow me
calculator?
more time
Oh, I
to
have
put
to
in
do.
volume into that
60
floppy.
kilograms, what should the
But
volumes
if
be?
my lung is so
350.
tight, because that rubber band is so tight,
350.
it's that pressure,
no,
if
no.
I'm putting in 20 centimeters of pressure,
What is it?
I'm
10
gonna
to
reach
15
that
mils
pressure
per kilo.
sooner.
So 10
No,
times.
Okay, so I'm
600
gonna have a
to-
shorter
Mhm.
TI, a shorter I
To
time.
what?
So I don't have as
900.
much time
600
put
to
volume
900 would
in.
be acceptable. Now read
As
the
other
rest
one,
of
I
the
have more
scenario.
time to put volume
It's
in.
with an inspiratory
So my
pressure
volume's
of 20
higher.
centimeters of water pressure. The tidal volume achieved is 1100.
Right,
Does
so
that tell you
ready?
you have a problem right now?
Yeah, it's more.
Okay, so you
Right,
watch
so now
this,
hold on.
she's
The
got
patient
time.
complains of dizziness, lightheadedness, and tingling because it's blowing off
What's
too
the
much
volume?
CO2.
Mhm.
What's the cause of the problem?
One
How
more
would you
time.
correct it? Why is she having tingling?
Low CO2?
Low CO2, she's
450?
hyperventilating.
350?
And what's your recommendation?
4, maybe 4? Okay, so 400 tidal volume.
You
To
should
keep
decrease the pressure.
slow
And
breathe.
what was your
Does
time?
anything in here tell you she's breathing too fast?
2.13
No.
seconds.
What is the scenario telling you? Are you delivering
So
the
it's so
tidal
hard to
volume you should
expand
be
that lung.
delivering?
That we reached the pressure
The
in only
pressure is
2
too high.
seconds. When it was
Why?
easy to expand the
Because
lung.
what's the volume you're
it took
supposed to
us
be
6
delivering?
Yeah,
seconds,
900.
almost 7
600
Yes.
to 900.
to reach
Yes,
that
now if you
pressure.
had an
More
A, B,
time
C,
to put
D
more
answer,
volume in.
We could say she's
that make
breathing too
sense?
fast, and you would be marked wrong,
Right.
because nothing in here is
So-
telling you that, but there is a big
sit down and
red
answer these
bullseye in
questions.
there that says the exhale tidal volume is 1100. That's way too high, so you have to fix it by dropping the pressure.
Okay, what's the answer to this question?
I'm gonna set up a V60, you guys wanna take 15 minutes, do you wanna, grab a bite to eat or something in your
Mhm.
car, take
Stop,
15 minutes and then
decrease.
come
Tidal
back
volume
up and we'll
decrease,
start on the
decrease. Go to that
bypass,
second one.
okay?
Yeah.
Joni, can I, pull these down?
Yeah,
Okay.
there's a resistor right there on the other side of the machine,
Okay, thanks.
TI is decreased. What about
Did
the third
you
one?
feel like you learned